Nearly 1 in 5 Medicare patients returns to the hospital within 30 days of discharge. It's estimated that this high readmission rate adds more than $17 billion to the country's health care expenses. But at UMDNJ, the University Hospital in Newark, New Jersey, the iCare 4 Healthcare Transition Project is helping patients with multiple chronic conditions to receive intensive case management to help them avoid rehospitalization.
We had a previous study on diabetes that focused on transitioning patients from the hospital to the home setting. And we found that a lot of times patients found it difficult to manage their medication regimens and needed a lot of help and support with not only understanding their diagnosis and the medication and treatment plan, but also just needed someone to support them and help them stay motivated to stay on track. And so one of the things we realized was that oftentimes patients would come back into the emergency room because of a medication problem, because they run out of medication, or the medication, maybe part of the prescription was missing and it needed to be what we call reconciled. And oftentimes when they would come back for that in the emergency room, they might find that a symptom has not been resolved or is exacerbated and there's a new problem, and it would lead to a readmission.
It's a 4-tier approach through which a patient navigator visits patients in the hospital prior to their discharge and introduces them to the program. After the patient enrolls, a registered nurse, an advanced practice nurse, and a team of physicians collaborate to help each patient until that person can see a physician regularly.
I'm the clinical program director. Dr. Scollan-Koliopoulous is the investigator, the principal investigator of the grant. And together we've put together a team that meets the patient at the bedside in the hospital when they are first admitted. And we do an intake and ask the patient if they would like to participate in our transitional care project. And then our healthcare navigator will contact the patient once they've left the hospital at 24 hours, 48 hours, 72 hours, up to even several weeks down the road. And again, the whole concept is we want to make sure that patients are getting what they need even after they have left the hospital.
I told you the name of our program is iCare for Healthcare Transition. And that transition part is that of trying to help our patient from having readmission. How do we do that as a team? Like we were speaking with Dr. Melissa and Dr. Blaise and myself. We work with you, as I'm doing now, at the bedside first. Since it's only your second day here, I'm going to come and make sure everything's, you're doing okay. You might have extra questions. And like I told you, I will bring the materials that you need in reference to what we had spoken earlier. And that'll be given to you of the day of discharge.
And the way we communicate the program is by having the co-director on the project, Dr. David Blaise, go to rounds periodically where the internal medicine residents discuss their admissions, and he helps them identify who's at risk for readmission and who might be a good candidate for the program. And then what we do is we just round on the floors, and we'll meet with the discharge planners and case managers and just ask, is there anybody that you have that you've admitted today that could use some help when they go home? And how do we define if they need help? Well, right now we're defining it as somebody who has not established a relationship with a primary care provider, first and foremost. That's our primary concern. And the second way to get in the program is to also live in the Newark area so that it's easy for us to visit the patient and work with the resources we have close at hand.
Morning. Good morning. How are you doing this morning, Mr. Alonso? Doing okay? Were you able to fill the paperwork in the folder?
Yeah.
Okay.
Last thing, some water.
You want some water?
Yeah.
Oh, okay. Okay. Well, oh, definitely. Okay, we'll get you some water.
How you doing?
How are you?
All right.
How you feeling today?
Did you cut or not?
Well, I'm feeling better than that before I came here.
Are you happy to be in the program?
Patients enrolled in eye care receive self-management support prior to being discharged.
Okay, I'm going to give you some ideas for breakfast, okay? Omelet is an easy one. That includes your eggs, and you can have some toast with it, okay? You can put some turkey sausage or, if you like, in there to up the protein value. Cup of milk and a piece of fruit, and that includes everything in here. This is the plate method, okay?
I think it's that visit that's happening every day in the hospital and those telephone calls. We're not just waiting for the patient to call us. We call them and reach out to them. So we're not saying call us if you need us. We're saying we're going to call you, and we do call.
Hi, Mr. Alonzo.
Yeah.
Hi, how you doing?
All right.
Good. Okay, Dr. Closer see you this morning.
Yeah.
And she discharged you. You're going home. And I'm here to give you instruction.
Okay.
Okay. All right. And I have a prescriptions for you. And she gave me a list of prescriptions. You got the glucometer, the lancet, and the strip.
Well, to date, our early care transition outcomes from our first year of our project, where we've recruited over 200 patients, what we found is that there was a positive improvement in quality of life, both physical, mental, and I should add social well-being. There was a clinically significant and statistically significant improvement. There was the same went for medication adherence, clinically and statistically significant improvement in medication adherence. And what we found was, and I'm not going to say it's just from our program because there's lots of initiatives going on at University Hospital, but there was a 40% reduction in readmissions, in all-cause readmissions from before we started the project to the end of the first year, which makes me feel as though we are making an impact. So primarily medication adherence, emergency department visits went down as well, and patients are getting in to see the primary care physician sooner. We started with a 48-day wait, and now it's down to an 8-day average wait for somebody to get in to see a primary care physician. So it's working with the system at all levels. We're seeing systems level outcomes, we're seeing patient level outcomes that are very important, and we're seeing improved quality of life, which is priceless.
My name is Crystal, and I'm from Newark, New Jersey. And I was introduced to the eye care program when I was rushed to the emergency room with a sugar count of 903. And I could have went into sugar shock, but I was educated with the eye care program, and they taught me a lot about carb counting and what foods to eat and what foods not to eat, what food could bring your sugar up. They taught me, you know, about the fruits that had a lot of sugar in it. It's a lot to learn when you become a diabetic. It's something that you really need to, you know, take really charge of in your life, because some people were successful with it and some people aren't. I'm just one of the lucky ones that I was able to come off the insulin in 6 months. I lost the weight. I lost over 30 pounds in 6 months. And I'm just happy that the program was there for me and taught me what I needed to learn.
What I'd say is if somebody wanted to replicate our program, it would be a team approach where we have the patient, we have the nurses and discharge planners at the bedside and the hospitalist physicians. And then we've got the navigator, the nurse practitioner, and the collaborating physician all working very closely together to case manage the patients. And also very important are the talking points that Rosa uses. She doesn't just talk off the cuff. I mean, she does have some scripted talking points that she adheres to. And those talking points are based on the evidence of what's worked in other trials and interventions to promote regimen adherence.
At University Hospital, we are committed to reducing readmission rates for all of our patients. We realize that it is in the best interest of their care and treatment, that we're going to be focusing on their specific needs when they get back home in terms of reaching their primary care physicians and having the ability to seek prescriptions and having the ability to contact our patient navigators whenever they feel distressed or in need of talking to someone that understands their particular point of view from a healthcare perspective, and an effort to overall improve their individual health status and that of the cities and communities that we serve.
Eye care targets patients who do not have a regular primary care physician and have one or more of these conditions: diabetes, cardiovascular disease such as heart failure, uncontrolled hypertension, and atrial fibrillation, respiratory disease such as asthma, chronic obstructive pulmonary disease and pneumonia, HIV, and sickle cell disease.
I'm glad I'm able to come here and share my story, so this way I can help others and encourage others to join the program and learn as much as you can about being a diabetic. It's a tough road, but you can make it. It's a hill, but you got to climb that hill. Once you get over that hill, it's smooth sailing. You just got to be willing to do the work. You got to be willing to do the work. The eye care program is there to help you, and if you take advantage of it, it's the best thing that happened for me. It could be the best thing that happened for you.